Hi everyone, welcome to week 6. I'm going to take the next few moments and share my screen with you. So you'll see your week 6 reading assignments in Bates come from chapter 9 and chapter 24. Both of those are filled with excellent resources for you on mental health, cognition, and the nervous system. Your week 6 reminders. So you will be completing 2 shadow health modules, and this will be your neuro and your mental health and shadow health. Your QBank modules, again, will be neuro and psych. You'll be completing your neurological examination on video, which you'll be submitting to the Dropbox with an associated SOAP note, and I'll spend a good deal of time going over that. In week 6, you'll also receive your email from Dr. O, and this will discuss the policies and procedures for your 3P APEA exam. So make sure that you watch that video posted in the sync session about how to sign up through ProctorU to schedule your exam. So I want to take just a few moments and talk about the really good content in your reading this week in Bates. And so mental disorders in primary care are certainly something that you're going to come across. Approximately 20% of primary care outpatients do have mental health disorders, and 50 to 75% of these illnesses are undetected and untreated. So the prevalence of mental health disorders that you'll likely see involve anxiety, mood disorders, depression, somatoform disorders, and alcohol and substance abuse. And some common symptoms that you may encounter related to those are anxiety, excessive worrying, mood changes such as sadness, flat affect, hopelessness, memory changes, as well as unexplained symptoms and illness. Key components of a mental status exam includes assessing the appearance and behavior. That might include level of consciousness, posture, dress, grooming, hygiene, expressions, affect, and manners. The language and speech of the patient, their ability to articulate, the rate at which they're speaking, their volume and fluency, their mood, their perception and thoughts, their judgment and insight, their cognitive function, as well as orientation, attention, memory, and abstract thinking with cognition. So recording that behavior and mental status, there is an example for you on page 262. When it comes to depression, there are several risk factors: personal history, family history, stressful event or a life change, a death of a family member, a childhood trauma, disability, chronic illness, certainly with frequent symptoms impairing their quality of life, gender, more specifically females than males. So you want to be sure that you are performing these screenings and using open-ended questions. This PHQ-9 is a questionnaire which you will come into contact with several times in clinical as well as in your own clinical practice upon graduation to screen for depression. So this is just a screenshot. Now, understanding suicide. So the U.S. Preventative Services Task Force does not give us recommendations rating this for screening. However, we do need to discuss suicide. It's the 10th leading cause of death in the US. In 15 to 24-year-old age groups, it's the 2nd leading cause of death for those ages. And in American Indian, Alaskan Natives, within that age range, that's the highest precipice of death in any race and ethnicity. The highest rates that we see of suicide are in 45 to 54-year-olds, as well as elderly greater than 85. Rates are 4 times higher among men than women. Men most times by firearms, and women by poison or intentional overdose. So I have included some resources here for you, and I do recommend that you take a screenshot of these and copy these so you have these available for your own patients while you are attending clinicals. Now, when it comes to neurocognitive disorders, there's a spectrum of cognitive decline, and that's discussed in your book. That can be age-related, mild cognitive impairment, Alzheimer's disease, and other dementias. There's also a confusion assessment method with a diagnostic algorithm, and I've marked that box and page for you. When it comes to delirium and dementia, there are clinically features that will vary in those, including their differences in onset, the course, duration, and sleep pattern. Causes may be secondary to another condition and reversible, or they may be permanent. With substance use disorders, the U.S. Preventative Services Task Force recommends this as a grade of B, screening all adults 18 and up, including pregnant women, for alcohol misuse and behavioral interventions for engagement in high-risk behaviors. Although these questions are asked in the social history, be sure that you're reviewing them at every single visit with your patient. And these should include tobacco and nicotine use, alcohol use, marijuana, even if prescribed, and then non-prescription drug use. You never want to imply any bias. You never want to have a demeaning attitude towards your patient when it comes to discussing their use. You do, however, want to make sure that you offer support if they want to make a change, letting them know that you are there and available. When it comes to the structures of the brain, each aspect has its own function, and so this should be a review of pathophysiology for you. Risk factors for ischemic stroke. So several of these are not necessarily inherited conditions, but may be conditions that are acquired. So some of these have modifiable risk factors, and we'll discuss those in a little bit. You have atrial fibrillation, which again can be acquired, however, reducing the stroke factor risk while on aspirin and less contraindicated. With hypertension, reducing the risk with management of medications and lifestyle changes to control blood pressure. With hyperlipidemia, statins decrease the risk of stroke, ischemic specifically, by 20%. Diabetes with blood pressure control, statin compliance, and blood glucose control, all of those can help reduce the risk factors even if that condition occurs. Smoking and tobacco use increase the risk 2 to 4 times for ischemic stroke, so always offering cessation. Increasing physical activity. With chronic kidney disease, we see a decreased glomerular filtrate rate, or a GFR, increases someone's risk of ischemic stroke. With weight, a BMI greater than 30 increases the risk 64%. Diet, so increased risk with diets heavy in red meat, sodium, and sugar, as opposed to decreased risk with diets heavy in nuts, olive oil, fish, fruits, and vegetables. Alcohol heavy use can be shown to have ischemic stroke risk. Coronary artery disease with medication and carotid endarterectomy, those can absolutely help decrease the risk. Sickle cell disease, we see decreased risk with packed red blood cell transfusions when necessary, and then obstructive sleep apnea with CPAP compliance. When it comes to seizure disorders, there are several different types, and this fall under the neurological system. So there are focal, there are generalized, and then non-epileptic or pseudo seizures. Febrile seizures do fall in this group. However, they're usually benign due to a fever and self-limiting upon the fever resolving. There's a lot to know in neuro, and your book does a very good job at covering a lot of different things, such as movement disorders, tremors, tics, paralysis, palsies, autonomic disorders, parasympathetic disorders, syncope, dizziness, and weakness. So those are the things that we want you to take special interest in your reading this week, as they are not necessarily covered on your exam or your rubric. However, they're very important to know clinically as well as for your board's exams. In terms of headaches, these are, again, something that I'm sure by the time you're done studying, you've experienced. So primary headaches come from tension, migraine, cluster, or chronic daily. And risk factors can include obesity, having more than 1 headache per week, caffeine, and overuse of headache medications for greater than 10 days a month. Now, we're going to talk a lot about cranial nerves tonight. And something that your boards loves to ask you about is, what do the cranial nerves do? And are they sensory, or are they motor, or are they mixed? And so I've just created a table here for you. When it comes to reflexes, you'll see that the reflexes are elicited by certain innervation and control certain nerves. So again, there is a review here for you. With special tests, you'll find that Bates discusses specifically with meningitis on nuchal rigidity, Brudzinski sign, and Koenig sign. Those are important to know, especially if you're seeing somebody with neck pain, to differentiate the cause. With lumbosacral radiculopathy, another special test is the straight leg raise. And there's a figure there for you as well as the page that it's found. For asterixis or flapping tremor, that's concerning for metabolic encephalopathy. Again, there's a figure to show you what that looks like in the page number. And then for those of you in the ICU, in RN practice, I'm sure you have a very good experience with assessing the comatose patient, but there is a good review in Bates for you if you'd like to see that. So what belongs in a neurological exam? According to the American Academy of Neurology, the guidelines for screening neuro exam, you're going to assess mental status, cranial nerves, specifically looking at visual acuity, pupillary light reflex, the extraocular movements, hearing, facial strength, and speech. When it comes to motor function, you're assessing strength. For reflexes, you're assessing deep tendon and the plantar response, sensation, coordination, and gait. There's some specific anatomy that we need to know when we're talking about the neurovascular system. And so these structures are found within the brain and their functions, as well as neurotransmitters. Key skills when it comes to our neurological. So again, cranial nerve review. Cranial nerve 1 is going to identify familiar sense. 2 is our fundoscopic exam and visual acuity. 3, 4, and 6 are going to look at eyes in different ways with extraocular movements. Cranial nerve 5 is going to be a mixed, so it's got that motor of opening the jaw against resistance, and then superficial pain and tactile sensation is sensory. Cranial nerve 7 is smile, frown, puff out the cheeks, showing the lower motor of number 7, and wiggling the brows, squeezing the eyes closed shut very tightly is the upper motor of number 7. Cranial nerve 8 is the whisper test, Weber, and Rennie tests. Cranial nerves 9 and 10, in lieu of the gag reflex, is when that uvula rises and is midline and the swallow. Cranial nerve 11, when you're shrugging your shoulders, that trapezius strength and lateral rotation of the neck against resistance for sternocleidomastoid strength. Sticking out the tongue midline and pushing the tongue against resistance inside the cheek is cranial nerve 12. We do talk about sensory as well, and so superficial pain and tactile sensation, vibration sense, 2-point discrimination, and joint position sense or proprioception. Stereognosis and graphesthesia all involve sensory, whereas motor, we're looking at the muscle groups comparing side to side of the upper and the lower. Reflexes, we're looking at our biceps, triceps, brachioradialis, patellar, Achilles, and the plantar babinski, which is superficial. And then for cerebellar is mostly our gait, so that tandem walking, heel walking, toe walking. For Romberg and pronator drift, and then rapid alternating movements. So these are the things we're going to cover related to your rubric. This is your rubric in a nutshell with some specific notes here for you. So when you are doing your exam video this week, you need to focus on making sure you have all of these items addressed. Again, you should not be using notes. You should not be stepping out of the camera view at any time. So please make sure you are watching your video before you submit it to your instructor. If you are outside of the camera view, you will be asked to film that video again and resubmit. You need to make sure that it's set up possibly in a corner or in a very wide angle because you will be performing gait testing and having your patient walk. You can adjust your camera as long as you are still within the frame during the entire time. You should not be blocking your patient at any time. We should be able to see you and the patient, as well as you performing these skills, verbalizing and articulating what you're doing correctly. So when it comes to cognition, you're asking your patient and specifically assessing their level of consciousness. You need to describe that, assessing their orientation to person, place, time, and event. Their speech must be verbally stated that you are assessing their speech pattern. And you can state that after asking their person, place, and time. With memory, you want to have them perform a skill of recent and remote memory. For reasoning, you want to ask a question to see if reasonable judgment. If they saw an accident happen, would they call 911? You would ask a question of reasonable judgment. Additionally, and I forgot to mention this prior, always remember that you do have to obtain consent at the very beginning of your video. We cannot accept your video without consent. So now onto our cranial nerves. And a lot of this will be your review of the HEENT, which has some additional focus here on cranial nerves, specifically the neurovascular system. So the patient is identifying scent with eyes closed, and they are occluding each nair independently. In light purple, you'll see some helpful tips on where to find this in your Bates book. So I'm not going to cover those as they are specifically in your Bates book, but I did include these to help you learn and understand where that information is. For cranial nerve 2, your optic nerve, you're going to be using your Snellen chart, that pocket eye chart. You're going to do that about 6 feet away from your patient. And you can do that from fingertip to fingertip. In length, that's about 6 feet, and that simulates a 20-foot testing. It's always good to ask about color vision, as this does fall in the optic nerve. So on the back, there's usually an orange or a red and a green, and you want to make sure that the patient can see those colors. If not, you would understand that the patient does have some limitation in color vision. For peripheral vision, you're testing the visual fields by confrontation in each eye. Fundoscopic, verbalizing the visualization of the retina, optic disc, and vessels. And then you're performing the procedure safely. So you're using your right eye to the patient's right eye and your left eye to the patient's left eye. With cranial nerve 3, your ocular motors, so this is going to be the first of those extraocular movements. Specifically for number 3, these are in an X-based pattern. It does not include the lateral medial downward. For pupillary reflex, you're going to be looking directly and consensually while using your pen light. And then you're also going to be assessing for nystagmus. So this chart, this picture should look familiar. This is from Bates, and this does show your cranial nerves in a better distribution here to give you a good visual. For cranial nerve 4, that's your trochlear, and that's downward and medial, and cranial nerve 6, abducens, and that's laterally. Cranial nerve 5, you'll see I skipped over as I included all of those extraocular movements together, which is a good way to learn those. But for trigeminal or cranial nerve 5, you're going to be testing bilateral sensation using sharp and dull. So you can use several different objects for that, but you do need to assess sharp and dull of the forehead, cheek, and jaw. You need to see that the patient can open their jaw against resistance. This is something that we do often see missed on the exam, as it's done so frequently, but you forget to verbalize it. So I did put a note there to pay special attention to that. Cranial nerve 7, which is your facial, this is going to be demonstrating wrinkling of the forehead, puffing of the cheeks, or smiling. For cranial nerve 8, your acoustic or vestibular cochlear. So whisper test or watch tick. If you're using the whisper test, you want to make sure again that you are within the frame of view. A watch tick does have to be an analog watch. For your Weber test, this is going to be using your tuning fork. So you're going to be placing that midline on the patient's scalp or forehead, and you're going to need to know, does it lateralize? Do they hear it louder in one ear or the other? You need to make sure you are doing this properly by holding it at the base. So you're striking it first and pinching it, holding it at the base. The picture that you see below is a really good demonstration of the Rinne test from your Bates book. And this is when you have that struck and then placed on the mastoid process. So you'll see where they're holding it at the base of the tuning fork. That's going to allow that vibratory sensation and the sound to continue. Once the patient stops hearing it, you should be counting it during that time on the mastoid process. You're going to then not strike it again, but move it in front of the ear. And so you're going to count how long. Now, air conduction should be longer than bone conduction in a normal test. So you want to coach your patient, as this could last 30 to 40 seconds aside, depending on your patient's hearing. So you could do 2 to 3 seconds and then again move in front of the ear in 6 seconds. You need to definitely perform that on both sides for full credit. For cranial nerves 9 and 10, your glossopharyngeal and vagus, this is going to be your uvular movement. So visualize and instruct the person to say ah. And you can see this visualization here from your Bates textbook again. Asking the patient to swallow. We're not going to utilize the tongue depressor, as this could elicit the gag reflex, but we would verbalize that you could use the tongue depressor instead of actually performing it. For cranial nerve 11, your spinal accessory, you're going to have your patient shrug their shoulders against your hands while you're exerting downward pressure. This is going to be testing the sternocleidomastoid muscle. And then for trapezius, turning the head against resistance. So you're pressing up against their face as they're pressing against you for resistance there. Cranial nerve 12, your last cranial nerve, is your hypoglossal, and this is moving the tongue in a midline to test tongue strength. And so Again, this could be done by a tongue depressor or have the patient have their tongue pressed up against their cheek where you're able to visualize there for strength. So when we talk about cerebellar function, specifically, this has a lot to do with your gait. So general gait is that you can have your patient stand up, walk 2 to 3 steps. Tandem walking is going to be when they are walking heel to toe. And so an abnormal finding, if they're not able to do that, would be ataxia. You want to make sure that you are close to your patient at all times so they do not fall. 2 additional things with walking is that they're able to walk on their heels for a few steps and then walk on their toes or tippy-toed. For the Romberg test and pronator drift, you want to make sure that you are standing close to the patient, not allowing them to fall while they're closing their eyes with their palms up. Rapid alternating movements, you can choose one of 2 tests here. So hand supination, pronation on the lap, or the finger to nose, then touching the finger testing. And again, there's very good demonstrations of those in Bates for you. For sensation, joint position sense, which is your proprioception. So while the patient's eyes are closed, you're going to perform that. You can see some abnormal findings there and what they could be indicative of. And then your 2-point discrimination. So you're going to basically move a joint up and down, and you're going to have the patient tell you what you're moving and what direction. For stereognosis, the patient's eyes would be closed while you place an object in their hand. This could be something as simple as a coin, a key, a pen, and they would be able to detect that. And so you would perform that bilaterally in each hand with a different object. Whereas graphesthesia is going to be the patient's eyes closed while you draw a letter, number, or shape in their finger or palm. So something you would need to make sure of there is that your patient is literate and could understand what you're doing. So something simple like a circle or an O, or drawing a number like a number 3. For your upper extremities and testing sensation, you're going to perform that bilaterally for superficial tactile using a cotton ball and then pain with a pinprick or sharp edge. And then lower extremity, you're going to again do that on 2 sides. So you're going to do the cotton ball and pinprick on your right and your left. With vibration sense on the bony prominence, there is a picture here of using the tuning fork to do that. And so you could do that on the knee, you could do it on the ankle and the toe as you see, but you should do it on an upper and a lower. And that you're instructing the patient properly while you're performing these. Now, motor system, when it comes to your upper extremities, you're testing the deltoids, triceps, and bicep muscles for strength. You're comparing those side to side, hand grip strength as well as finger strength. And then for lower extremities, you're going to be testing the quadriceps, hamstrings, hip abductors, and the adductors. And again, the strength in comparing side to side. And you can see a demonstration there of how those are documented. For your deep tendon reflexes, this is how you should be holding the tuning fork and striking. So you should be testing and performing these bilaterally on the biceps, the triceps, the patella, and the Achilles. And then testing the plantar reflex at the Babinski for superficial. Now we've covered everything that you need to know in your video. Everyone has attended immersion by this point, so you should be wearing your lab coat in professional dress. You should have consented your patient and had good flow of those. Now we're going to be talking about your documentation. So your documentation is not going to align with your video as you are doing a SOAP note and not a write-up this week. So remember, a SOAP note is going to have your subjective, objective, assessment, and plan. So what is expected in your documentation in order to earn full points here? So APA format is 5 points, whereas spelling, grammar, and medical terminology use is 10. You're going to need a title page, use of headers for your SOAP note, medical terminology, in-text citations for the rationales on your differential and plan, and a reference page. So again, you're getting full points by doing all of those things appropriately. When it comes to subjective, what goes in your note? So every SOAP note is going to include these things. So your ID section, including all elements. And so that's going to be your patient's initials, their age, their date of birth, and you can make all of those things up as you're going to decide on a chief complaint here. You need to know if they came to the clinic alone and if they're a reliable historian, as well as their date of birth. The chief complaint, you're going to decide on a neurological complaint for this week's SOAP note. So you'll have plenty of time to take a look in your book, read several different things, but you want to make sure that you are including everything that you should based on the chief complaint you select. So that's going to include a very thorough review of systems for neuro and a very thorough examination for neuro as well, that you're going to have differentials that are appropriate as well as your plan. So in your HPI, you should be using old cards. This should be based on the complaint that you chose, that you're asking the onset, location, duration, aggravating, alleviating factors, if there's been any treatment, the severity of the symptoms. For past medical history, you would always document this, and if there's any pertinent specifically, those are important to mention, or surgeries, specifically like back surgery for neurovascular. Medications, you want to make sure you're always including their medications and any allergies. For immunizations, you can say up to date, as these would be pertinent or general. Social history would definitely include those if they are pertinent to your patient. Sexual history, again, if it was pertinent to the patient. Family history and any social factors. You still want to make sure, again, that you're asking that tobacco, alcohol, and drug use. Earning full points, you're going to do a pertinent to the complaint, HPI, and review of systems, as well as your past medical history. So you do not need to list every single thing that you learned about this patient like you did in your week 1 in a wellness exam or a comprehensive. This is a focused, a problem-focused SOAP note. So it needs to be based on the concerns that the patient is in the clinic for that day. The information should be clear and concise and not superfluous. With your exam or your objective findings, so this should include vital signs, and again, you can make those up. You're not doing that for the portion of the video. This is just your documentation. So what do I think goes in a neurovascular exam here for your documentation of your exam? Always include constitutional. That should be how your patient looks to you, because these are your objective findings. Their head, eyes, ears, nose, throat, and neck should be detailed. You should have, it should not say basic there, it should say detailed for neuro, because that should include your cranial nerves. This was copied over from the HEENT. Cardiovascular and pulmonary, you do want to have basic. Lymph nodes, you could go ahead and strike out there because you won't need those. And then skin, I always recommend putting an assessment of the skin, just a basic one, that it's warm, dry, intact, and no rashes. For earning full points, you're going to make sure that that is organized and thorough. Again, the pure focus of this week is putting a very good detailed neurovascular examination together. And you can use your Bates book for that. What you do not and should not ever be using is a template that you find online and just transferring that over as your own work, or someone else's work who had previously taken this class. Those will flag and turn it in. You will get a 0 on your documentation, and it will be an academic misconduct violation. So please make sure you are using your own words. We know that you're going to use medical terminology, but the pattern in which you are writing this should be your own. So read several different resources, but make sure you're writing it in your own way. For the assessment and plan, you're going to have 3 differential diagnoses based on the chief complaint that you decided upon. You're going to have a rationale for each and in-text citations as pertinent for any clinical practice guidelines or how you ruled that in or out. You're going to select a final diagnosis, and then in your plan, you're going to have diagnosis and any labs or pertinent imaging that's needed. Treatment plan with prescription, again, if that's pertinent for you. Referral plan if needed. Education, you want to make sure you're always being very thorough in your education to the patient on their diagnosis, signs and symptoms to expect, medications you're prescribing, how to prevent or avoid symptoms related to that condition, and then very important, or what are the red flags that that patient needs to watch out for? What is the time when they need to escalate their care? Not call you in the clinic, not call you after hours, but go to the ER for. A follow-up plan, when should they be seen back in the clinic? Or if it's a self-limiting condition, you do want to mention that. So full points is going to be earning the, you're going to have all 3 of your differential, as well as why you excluded some, your final assessment diagnosis clear, even if it may not be 100% correct, and your plan. So this is what that SOAP note documentation looks like there. We've covered that in detail. Again, you're going to want to make sure that you are focusing heavily on neuro. So If GI, GU, musculoskeletal, and tegumentary, and psych are not pertinent to your patient, you do not want to focus heavily on those, but you do in your review system want to ask about specific symptoms related to those body systems that I've mentioned. So the big bold ones here, these smaller ones only if they're pertinent. Objective, again, we covered that. And then in Bates, on page 860, there's a pink box there that shows you the key components of a neuro exam. For your assessment, there's differentials. And then what are differentials that you may see in a clinical setting? So this should not be your differentials for your SOAP note, but what are particular conditions that somebody may come to primary care for? And so this is a list here that is not comprehensive, but it does list several different conditions. So you can take a look at these, but likely these will be very few and far between for your well patients. You may see these for symptomatic visits or for chronic conditions. So please make sure your differentials are specific to your chief complaint and your patient. Your plan, as we mentioned, is going to be very specific with labs and imaging, what kind and why, your treatments. And that is all I have for you this week. So it is a lot to cover when it comes to neuro. Neuro is one of the most comprehensive body systems, and there's a lot to learn when it comes to neurovascular disorders. So please make sure that you are reading your Bates book. I know there are not quizzes associated with those outside of your Q banks, but it's very important to have a very good foundation for your pathophysiology that you've already covered, the pharmacology that you're going into for your 3PA PA exam, and then your physical assessment, which we cover in detail. Please reach out to your grading instructor if you have any questions. I wish you all the best.